So I will give you various situations for debate. We will be debating for different types of airway. So, grade 4 OSMF, what kind of intubation generally we do in such cases? Right. So now I will give you the situation. The anesthetist is newbie. 4 times he has retrieved the scope out of nostril. Bleeding is induced. Everything is hazy. Patient is awake. Now what will you do? Will you perform tracheostomy and finish the SMF case? What will you do? No, that is what we are doing. What is threshold of trying? I am asking you. What would be the threshold for trying? When should we intervene?
So normally when we do fiber optic intubation, we try to intubate the patient directly in the awake condition. But once it starts bleeding, it's difficult to see the airway, then we stop it. Then we postpone it for some time. We do a suctioning, we do some...
What time?
Like after profuse hemorrhage or something, we stop it for some time, and then after achieving hemostasis, we'll try again. Or we can directly go for tracheostomy at that time.
So if we are doing tracheostomy, whole purpose of doing OSMF surgery gets forfeited, I think. If I am not wrong. So we are doing mouth opening surgery, right?
Yeah, but if we are not able to achieve the hemostasis, then
so we can postpone the procedure.
We have to secure the airway first. If you are not able to control the...
No, this is awake fiber optic intubation.
Have you tried blind?
No, we have,
this is not working, then I should be fine. No.
So this is what I am asking. In similar situation, I have been stuck in the past. That's why I am asking.
So there is no trick question. It's a genuine question you are asking. Is that, or is it a trick question?
No, sir. There is no trick.
So I think why not consider tracheostomy then? No.
But sir, this is mouth opening surgery. Patient is awake. Why you want to create
fiber optic intubation?
No. I mean, there is no clear-cut answers for this. But this is a mouth opening surgery. Tracheostomy is for a life-saving situation. Then it's a different matter. You can safely, honorably postpone. You should have a better. I've had a situation. There was a case of the TM joint replacement. The chest physician had gone for the conference. R4 had come. She tried for 45 minutes. Then I took over. I did the intubation. But if I could not, I would have postponed the case. I would have not done even for the TGR.
There is one more technique which is retrograde, right? That can be done.
No, but this is failed at the same time. At one go, they tried and failed 4 times. Or
at least for half an hour he was trying, and 4 times he has withdrawn the scope. So I did it on the next day. I postponed the procedure.
Yes. See, I will tell you, this is something that everybody needs to know. We also had a ankylosis case. Guys, please listen here. We also had an ankylosis case. Again, the same problem. They had already tried intubation some 2 years back. Failed intubation attempt, failed fiber optic, and then again they tried the same thing. Okay, and then they tried so many times. There was so much of bleeding, so much of edema. Then they said, "Acha bhaiya, nahi ho raha hai." Then they said, "Okay, now we'll do a tracheostomy." A second-year ENT resident came and she tried to do tracheostomy, and then somebody else came, and then finally the patient, we had a DOT, death on table. Okay, this is something that just cannot happen to anybody. Please understand. So 4 failed attempts, you have to stop.
Fiber optic intubation in itself is a rescue procedure for somewhere we cannot intubate. Now, considering that fiber optic intubation was done by some anesthetists who've already been trained, only then they will take up such cases like this. Now, once they have failed and we have crossed our thresholds, in looking at the center of the care for the patient, why not consider doing tracheostomy and perform the procedure, completes a...
You can remove bleeding. Patient is awake. Managing the bleeding is not a problem. Okay. I was telling you about the case which I had some couple of months back or 4 or 5 months back, and I was sitting outside because I had a TJR. Didn't want to go inside. Said you go ahead. Just chest physician had come. But after then I said I'm going to try this. I'll try once. If I can, we'll go ahead. So luckily it's a lucky day I could do it. Otherwise, postpone. Because if it's life-saving, do it. Otherwise, postpone it. This is not malignancy surgery.
Yes. Okay. So my job here is to create a controversy put stalwarts into discussion and you will learn. Okay? So the second case.
So the question is not answered. What about if it happens tomorrow again?
Postpone again. If it's a malignancy surgery, there is no brainer.
It is not malignancy. Fiber optic intubation failed in mouth opening surgery.
But why will it fail?
Why did it fail on the first day?
No, the person who was trying, see, blind, can I, no, I want to make a point. See, there is a difference in awake fiber optic intubation difficulty for TM joint ankylosis case who has no mouthing for 20 years. That's much more difficult than a submucous fibrosis case than somebody with a post-radiation case. They're all different challenges. So there is no reason. If it's a post-radiation bleeding, I'm worried. But if it's submucous fibrosis, I'm not worried.
One more situation, a repeat tracheostomy. That is another problem.
Yeah.
Instead of so many situations, a repeat tracheostomy again might have a stricture. Okay, so a repeat tracheostomy stricture cases, you need to get a CT scan, CT neck, if it is a repeat.
Not all repeat tracheostomies, but there's something in your mind. So I think as an elective procedure, because you don't have a good chest fed guy or a good anesthetist.
Can we move on the next case?
We have only 20 minutes.
Okay. So bilateral TM ankylosis in 6 years old, severe OSA proven through the sleep study. What will you consider? Will you do it pre-operatively before surgery? Let's say 2-3 days before surgery, or whenever you have consulted the patient within 1 day or 2, or you will do it on table on the day of surgery. What would be the ideal approach for this particular patient?
Tracheostomy.
Ma'am,
Pre-op tracheostomy.
why?
Don't want to take a chance.
No.
She's a small child, so doesn't want to take any chance.
So it's a severe OSA, right?
Severe OSA.
Daytime somnolence, nocturnal desaturation episodes, and everything, metabolism, growth, everything is affected, right? So the minute you do the tracheostomy in such patients, they will feel so happy. You can see them roaming in wards, and your stress of the operating day reduced because there is already a tracheostomy. And in the post-op setting as well, in such cases, inevitably you will be doing distraction first. So our definitive area would be tracheostomy only in the post-op setting. And if some few days have passed, you can always change it in the surgery. So
I have taught you well. I mean, that is what I would do. If anybody has a different opinion.
Yeah, you can see it's 6-year-old, right?
No,
Why do you want
not 1 day prior. That's I think institutional. There are obligations. Of course, same day, but there are institutional obligations.
The problem with tracheostomy post-tracheostomy care is very difficult in our poor setup, right? People are so scared about it. Right now I have 2 patients under tracheostomy. One is with Shelley's tube, that is total synatia. It's there for 2 months. They are struggling to manage these things. I am keeping them in the ward. Another one is a 4-month-old baby. They are not going to remove. That's a peanut tumor in the anterior maxilla. I don't want a tracheostomy, but anesthetist insisted. They had a tracheostomy and they are not going to remove for 1 year or something like that because it's just 4-month-old baby. And the tracheostomy care from the patient's point of view, it's really scary, right? I don't want to, even I'm scared to send them home with the tracheostomy. It's not like abroad where they have all the facilities to reach out. They are in some poor villages. So all the more, for this case, particular ankylosis, we do plenty of ankylosis. I never do a tracheostomy. Always fiber optic intubation. Don't remove the tube for 2 or 3 days. But I had trouble, right? Where we had to do an emergency tracheostomy after 2 days, particularly in 4 years. 6 years is fine. 4 years is very tricky, particularly with severe ankylosis. I had 2 cases where we had to do an emergency tracheostomy. One really went bad. We had to recover. Luckily, we able to save the patient. So that is what I feel like. So,
Okay, sir.
tracheostomy, I'm still scared about, right? Post-op care, tracheostomy. That's more dangerous than other things, complications.
Okay.
Yeah.
So the next case would be malignancy, right? Carcinoma tongue, which requires partial glossectomy, neck dissection, and free flap. So these are my questions. Gunjan sir, which tube you will be using for the same? Size is decided at which step of tracheostomy. What should be the care of tracheostomy in post-operative setting? What kind of nebulization and decannulation protocol?
So this case, if we are going for a free flap and a tongue dissection, definitely our protocol will go for a tracheostomy. Whenever there is a doubt whether to go for tracheostomy, always we prefer to go for tracheostomy. We can decannulate the patient after 4 or 5 days if the patient is already been removed. And as per the standard size, usually as a size of endotracheal tube, the same size as endotracheal tube or one size larger we can select. I think Rahul sir might refuse to do tracheostomy, but if we are doing a free flap on the tongue, we'll always do tracheostomy.
No, sir will do.
But not for this.
Some free flap.
No.
Can I just, let me
Sir, resection and a radial for me.
No problem.
This is a very, superficial, very small lesion.
No, sir, photos are.
Can I tell you, without quoting anybody, I know in a metro place a surgeon whose protocol for a tracheostomy is a free flap. Now I think that's too aggressive. But having said that, let me tell you, tracheostomy is a very, very personal. There is a personal indication depending on the setup that you are in. If I am in Mumbai, a patient is from Mulund and operating in Borivali, I will definitely do a tracheostomy. So there are indications we need to respect that you can't copy and paste indications. And if someone is in a particular setup for TM joint ankylosis, somebody might do a fiber optic intubation. It's absolutely justified to do a tracheostomy for her situation. So we can't say it's wrong. And what is one question for chocolate question? What is the best time to do tracheostomy? One person. No, not for you. No, of course not for you. What is the best time to do tracheostomy? Yes, when you think the tracheostomy is required.
Give her, she heard 5 stars.
Sir,
Most of the elective cases. So
Rahul sir.
I just want to add one thing. Like there is a meta-analysis on overnight intubation versus tracheostomy. I don't remember in these cases for free flap. Some tertiary care centers, they keep the intubation overnight and they extubate in the ICU next day. When the flap is working, there is no sign of hematoma, nothing. So we can always do that. But coming to your question and your controversy which you have created, you carry on.
Now you can
On the third
remove the tube and then
on the third post-operative day, if the free flap has been done, oral cavity will be filled with so much edema. So putting only nasopharyngeal airway works. That was my question. Or you have to do tracheostomy. Now moving on the.
See, I just want to add up one thing. Technically, most of the elective, I really agree with Dr. Rahul. Elective cases, we do not want a tracheostomy. In my center, we hardly do tracheostomy, even for onco, even for free flaps as well. In case if somebody is not able to do a fiber optic intubation, please change your anesthetist rather than putting a blade into that.
Sir, question is if your flap will get congestion, if the tongue is filled up with edema, and what will you do on the third day?
Sir, in a center, most of the free flaps, we keep an overnight intubation and we take the intubation.
Do the tracheostomy on the third day.
No, it's not fair. It's not fair. Airway will be intact, definitely.
If I am in the same setup morning and night, I will.
so
But I can understand. if I-
Technically, you have a congestion on the third day means you are either your residents are looking at every once in 2 hours.
So the conclusion is it's a surgeon's choice. Surgeon's choice. The next
So in
case.
short, the elective tracheostomy is always better than doing an emergency tracheostomy. That's a
Yeah. Point well taken.
Young female benign tumor only involving central arch of mandible. Planned for free fibula, obviously, with good mouth opening. Tracheostomy, intubation, steroids, what?
Tracheostomy.
See, different opinions are different. Huh?
Does free flap indication? Does free flap needs to
Yeah.
put in as a factor?
No, free flap is 19 years old female. We will definitely do fibula.
But do it tracheostomy.
If you can secure the muscles, why do you need to put it
I am asking, I am youngster, sir. I am just a youngster. I am asking you.
Sir, in most of the cases in fibula, when you do a normal plating, the whole of the pedicule and the vasculature is on the lingual side. A number of times surgeons fail to secure it well. In those cases also, you will still have tongue fall there. So, as sir said, if you are doing in a very good center, surgeon specific, everything is under control, yes, you can try to avoid. But if all these things are not under control and if you are in doubt, I think doing tracheostomy will always benefit than not doing. At the mandible? Body of the mandible? Yes, sir.
I'll change the topic. I won't do even a fibula for I'll do it any case for this case.
So only central
Forget.
benign
This is too
cases
simple case for any case.
would
Benign
not be
tumor.
the indication for tracheostomy, right? We can get away with. Okay. I am asking you. So now there is an emergency call, right? Massive intraoral and external bleed in free flap treated patient. Probably sir have cut the posterior belly of digastric and did the anastomosis in the external carotid. Second postoperative day, you are receiving call from the hospital. There is massive bleeding, please come. What are your thoughts during the way and what will be your plan?
So, source of the bleeding, if it is, so
you have to assume because you have not seen the
so I
patient.
have assumed that probably it is either from
Second postoperative day, so highest chances
if there was some sort of infection and anastomotic site leak,
right?
Yes. It can come. If it is opened up intraorally also, it will come. A number of times. Another thing is distal end of the flap also sometimes opens up and it gives bleeding from there. So we don't know if it is from the neck or from the oral cavity. In any case, bleeding control and airway securing airway are the two primary objectives.
For our concept makes the patient sit and do suctioning, keep artery is ready at the bedside. All the things we have to first advise, and then we can reach the patient and then start our procedure whatever we want. If we are seeing that airway is not secured or airway is compromised, patient is not able to breathe, we can lateralize the patient, do suctioning, again try some intubation. If patient is hyposaturating, something like this.
Okay, so my second question would be, if you are there and you are performing emergency tracheostomy, we have seen some institutional protocol and we have seen some surgeons, the incision will directly go into trachea.
Yeah, vertically
right?
will give.
Should we do it?
No. I think first we should incise the skin, then dissect. If we are clear, then we can directly give a deep.
So that much of time we can always buy, right? 10, 15, 20 seconds.
So
there is no need of putting blade directly into trachea through the skin.
no, if you have a patient whose saturation is already gone beyond 40 of SpO2 and you have to revive this patient, then whatever you do is justified because you have already lost the patient.
Okay.
But if you have not lost the patient and you have luxury of time, you have to take a decision there and go through the skin, subcute, whatever you want to do, you do. If you have already lost the patient with aspiration and the saturation is already down, you can go with direct stab incision direct to the trachea also. Depends, you take it higher up. There is no contraindication for that. Whatever has to happen, worst has already happened.
Okay. So same thing, after we have discharged the patient, on the second day, you are getting call from patient's relative. There is massive bleeding, बहुत खून बह रहा है. So you are asking them कि shift to the hospital where we have operated. Now what will be your thoughts? क्या गलत हुआ होगा? What went wrong? Second post discharge day.
There can be any bleeder from the anus forces or other vessels would have opened up in the neck or something. So massive bleeding is to affect. So that's why we are
lingual artery, facial artery, anastomotic site.
Please talk into the mic and talk. Look there and talk. We are not discussing here now. Please look into the mic.
Why is this question, may I ask? You are now becoming, he is becoming very much head and neck.
Sir, airway will come after.
You have 5 minutes now.
Okay. So we will shift to the next case.
Situations he is putting.
Obese with short neck, but okay. Intact, central arch would be intact. You will do the neck dissection and locoregional flap. Now, what will be your airway management in this patient? Will you put the endotracheal tube and extubate the next day, or will you consider the trach? And expected cost of complications for putting just ET.
So I think there are so many indications for tracheostomy. One is short neck, one is obese, one is patients who have a history of sleep apnea. One relative indication is patients who are elderly with poor vital capacity. That is also an indication for tracheostomy. Forget anything else.
People have to ask you one.
So tracheostomy is so I have seen problems in patients who are just 70 and a small maxillectomy and neck dissection with poor vital capacity.
So I need to ask you one thing. Obese means what? What is the BMI? What is very important. Obese means what? Age, height, obese. Next question.
Short stature and increased BMI.
BMI more than 30. BMI more than 30. 35. That is obese. BMI more than 35. Yes.
So now if he's an obese patient, it's not going to be easy to mobilize him if you don't do a tracheostomy. And such patients, they deteriorate very fast. If you are an obese patient, lung capacity is already compromised, heavy body weight, you need to have aggressive mobilization of these patients. You have to do a tracheostomy.
In fact, anesthetists will not even induce. I had in a month 2 patients. One was 165 kilos, one was 140 something. Even intubation is not going to be happy ventilation. So you have to do a tracheostomy, and these tracheostomies are difficult tracheostomies.
You should always have a spare long flange tracheostomy tube if you're
You have to conclude this.
Yeah.
Because
in doubt tracheostomy.
yes,
In doubt tracheostomy. In a malignancy case, in doubt tracheostomy, no brainer.
even in any say doing it, overdoing it is still okay. Then not.
And everybody,
getting into
I think
problem.
the tracheostomy you should get familiar with.
Any questions so far? Any questions?
Okay, so quickly then next question. EF less than 35%. Otherwise, no other medical history. The physician has written the pre-operative fitness concern like this: due anesthesia and cardiopulmonary risk. That too is not enough, so final fitness will be given by anesthetist. Tracheostomy or extubation next day.
Get a stress echo done. If stress echo is good, don't do it. Dobita means stress echo.
Yeah, PSA.
Because you cannot run
So, space infection with raised tongue, minimal respiratory distress. Okay? SpO2 is fine. What will you do? Minimal respiratory distress. Today only, after giving antibiotic, you are going to drain. So, question of edema is not there. Okay?
Local mechanic. Even possible with deep cervical supervision.
So, if you are thinking it is too massive and the ET would be kept for more than 5 to 6 days, then better to do tracheostomy, right? Otherwise, ET can. Simultaneous orthognathic with rhinoplasty. Patient doesn't want submental intubation. What will you do?
Nasal intubation, why?
Simultaneous orthognathic with rhinoplasty. With rhinoplasty in the same setting. It's a very to be beautiful actress. She will be beautiful after surgery.
If a patient doesn't want submental intubation, she will not ask us for tracheostomy.
No, sir. What should we do? Anyone? No.
Different procedure. First we'll do the orthognathic surgery, after
Two-stage procedure.
Yes. Nasal intubation. Complete the bijaw surgery. Switch to oral route. Do the rhinoplasty.
No, this tube switch we have done a lot of times when we are using pancuronium. It's highly risky for anesthetic surgery. Please don't do it.
Yes.
Therefore,
Submental intubation. Otherwise, no to surgery.
That's right.
So take home message would be pre-anesthetic evaluation is very much important. The first one, reach operating theatre before induction, right? And inform consent, both written and video if possible. Learn basics and train yourself for unlikely, unexpected events. And again, train well during residencies. Maximum hands-on in ICU and ICCU, right? ET, change, tracheostomy, scopy, whatever. Thank you.
One thing I just want to ask. Free flap in maxilla. Because when you do the free flap in maxilla, the undersurface of the flap is raw. raw. So there is constant bleeding from the undersurface, and it collects into the nasopharynx, and there is a chance of aspiration. So what should we do? Tracheostomy or overnight intubation?
So if that is the only reason, the best way to avoid is pack the nose. I have a patient right now in Baroda.
And second would
pack
be
the nose
to-
and slowly get the ribbon gauze out afterwards. Don't go tracheostomy only for that.
Only for that.
Regarding what Rahul sir told regarding obese patient, and even Yash sir also told a long flange tube. Because when it happened, tracheostomy, the tube became short in a obese neck. So the distance from the trachea to the skin is too long for a tracheostomy to go.
Again, that in obese patient, you must not extend the head much for doing a tracheostomy. Because when you make them in normal position again, the tube has to come out.
True, but in cases we don't have a long flange tube,
You can use a flexometallic ET tube.
flexometallic. So that is a point to be taken, a flexometallic tube if you don't have a modified or long flange tube for a tracheostomy.
Always keep a 4.5 number ET tube ready in your OT if you are dealing in onco or any trauma. In case you don't get a tube inside, just push it inside. 4 number tube, just push it. It will save your time. It will save your time.
That 4.5 tube with the that select inside.